Thank you for the invitation. Welcome to our session. We have two interesting cases with severe aortic stenosis who are undergoing TAVI. The first case is a male, 79 years old, with dyspnea, NIHA 2 to 3. In his past medical history, he has undergoing aortic aortic valve replacement on 2021 with magna is 21 millimeters. He has a coronary disease with two grafts, one to lima lat and one to radial PDB. He has ejection fraction 55%. It is a normal ejection fraction. He has a history of paroxysmal arterial fibrillation, hypertension, diabetes, dyslipidemia, and baseline creatinine 1.2 milligram per dl. We can see his medication with Eliquis, with double antithrombotic, with Eliquis and Plavix. He also takes diuretics with Tormis and anti. And he undergoing coronary angiography, in which we saw that the left main was without relevant stenosis. Left arterial descendant artery was 100% closed, and the graft to lima and lat was okay. Circumflex artery was also has also stenosis 99%, in which he undergoing PCI at 2024. His right coronary artery also has 100% stenosis, and his graft at LRA and to RCA was 50% stenosis. From echocardiography, we can see severe stenosis, severe aortic stenosis with aortic velocity, with aortic jet velocity about 3.95 meter per second. Here are some measurements from angiography, CT angiography, just to find which is an appropriate size of valve. In CT angiography, we can see that left femoral artery has some calcification plaques, so we choose to go from right femoral artery. Here are procedural steps. We start with light sedation. Where we access from right femoral artery under echo guidance. and from right radial artery. Then we with no.
Yes, so just to put it in a nutshell, so we are dealing with a small, very small valve. It's 21, right, Ilias? Yeah. So 23. We have some axis issues, but in the iliacs and the abdominal aorta. But puncture sites look okay, and we want to have a good hemodynamic result by placing a proper valve, have a good expansion of the valve, check the hemodynamics later, and of course try to avoid any disruption in the stent frame, which is located in the iliacs and the abdominal aorta. So what do we do? So this is the normal procedure that we do. We do light sedation and local anesthesia. We puncture the arteries with echo guidance, and we try to pace through the wire, which is located which is placed in the LV to minimize any extra punctures and complications.
Here you can see the puncture of the right femoral artery, echo-guided as always. And
one of the discussions that we always have, it's when we deal with the valve-in-valve procedures, is whether or not to do predilatations. Mostly we don't do except if it's highly stenotic. And
so we see promising femoral access, no interfere at all with the stents in the abdominal and iliac arteries. And so we move on now. Here you can see the wire through the stents. We proceed to the prostyle implantation. Some heparin. And now we have to advance the pigtail 5 French to the aortic root from the right radial artery. Tortuosity, extreme tortuosity in the right subclavian artery. We advance second pigtail from the right femoral artery to advance the stiff wire. And then the sheath. Also, you can see the preparation of the valve. So we advance the sheath from the right femoral artery. And now we're ready to pass through the valve. With the AL catheter. So we managed to pass through the valve, and now we have the stiff wire inside the left ventricle.
So this is an Innovi wire, right? An Innovi, yeah.
This is a Safari.
Safari?
Safari small. So we proceed to the pre-dilatation. And here you can see the balloon inside the valve. It's a SIPCA 18 to 40. Now you see the pre-dilatation. Rapid pacing through the wire. And now it's time for the valve-in-valve implantation. The Allegra valve. Let's see again. The opening, it's characteristic. Okay.
Of course, as always, you have to pay special attention to the markers. You have to align properly the valve in order to avoid any interaction with the coronaries and to facilitate easiness of cannulation later on.
We've implanted the valve. And now it's now for some measurements. No gradient here, no peak-to-peak gradient, as you can see here. So it's a successful implantation.
So there is a valve indication with this valve, very good hemodynamics. Professor Oldroyd will talk later on that.
And now is our post-procedural echo assessment. No regurgitation. And you can see that we have a max aortic velocity at about 2 or something like that. We recheck the valve. So the final result is this. We have a max aortic velocity at about 2.3, and the final result from the femoral arteries, the final angiogram, you can see here, nothing left behind. The next day, echo, no regurgitation, 2.3 velocity.
So good. So thank you, Leah. So it was a relatively easy, I would say, procedure with careful steps. Of course, we try to not to interfere with the EVAR stand. Might have very important sequences. So that's why we placed the sheath in order, the 18 French sheath, in order to be able to disengage and retract the valve and then reload it in case that we were not successful in the first place. But this is kind of older, let's say, technology. Is the first iteration of the Allegra device, and now we're lucky enough. We're having Professor Oldroyd from Glasgow